Keratoplasty. Bennie Jeng, all yours.
Thank you very much, Ashvin and Deep, for inviting me to participate in this session, and a special thank you to Namrata and the AAOS for inviting me, as well as involving the AAO in this very, very special meeting. So I was asked to talk about what's new in endothelial keratoplasty.
Benny, your mirror, this thing is coming here. Presenter view is coming to us.
Oh, I don't mean to do it that way. Let me see.
Oh, it's still presenter view.
A swap display, I'm guessing.
Let's see.
Swap display.
Yeah. Is that better?
Perfect.
Okay, good. Excellent. Thank you. Okay, I apologize for that. So I don't have any financial disclosures. So I think to give any update, it's very important for us to just take a step back and remember how far we've come. And for those of us who have been in practice for a while, it's hard to imagine that 25, even just 20 years ago, people who came in with any corneal disease almost always got a PK, even for isolated endothelial disease. It was only 2 decades ago, not that long ago. And then 15 years ago, dissect came around, and the average thickness for a graft at that point was probably 150 plus microns. And so this is one of my first dissects here in the upper right. And then, about 10 years ago, we started to get thinner and thinner. And now we have ultra thin dissect. I usually do about 70 microns for my graft for that. And then about 5, 7 years ago, DMACC started to hit the ground, and you can almost not even see the graft in this picture over here. So, when DMACC came, and up to about 3-5 years ago, there was a lot of controversy as to whether or not DMACC, with all its inherent learning curve and complications, was worth it compared to what we thought was a really good procedure, which is ultra thin dissect. And there are a lot of observational studies, retrospective studies, looking at whether or not we should be concentrating on DMACC. And people ask for more data. And so in the last couple of years, we've actually had a couple of really good, smaller, but really good randomized trials looking at ultra-thin dissect versus DMACC. This is the DETECT study from Jennifer Rose Nussbaumer in San Francisco, and this one, the European study, both looking at comparing the two. And they both found, in essence, that a higher percentage of patients with DMACC achieved better visual acuity, depending on which study you looked at. In the DETECT study, they found that DMACC gave better visual acuity in general, and it was faster to achieve that visual acuity. And then subsequent studies and secondary studies have shown that there's less higher order aberrations, there's faster recovery of vision, less graft rejection with DMACC. And so I think a lot of people who do endothelial keratoplasty will agree that DMACC really has come around, and this is the newest thing in endothelial keratoplasty. And in fact, if you look at the distribution of tissue for the US eye banks, you'll see this green line right here is DMACC. And so from 2015, it's been on the rise. If you want to look at the raw numbers here, total endothelial keratoplasty procedures continues to go up and has surpassed PK back in 2011. And dissect numbers have slowly been going down, while the DMACC numbers from 2013 to 2019 have almost increased by 10-fold. And so DMACC is really taking off. If you look at the international eye banks, which have tissue supplied by US eye banks, similar finding. You can see that DMACC is on the rise here in green. So what's new for endothelial keratoplasty? Well, there's a lot of aspects of DMACC that are actually quite new, which I'm going to talk about. DSO is not really keratoplasty, and I'm not going to talk about it because Professor Mehta is going to talk about that right after me. Endothelial cell transplantation is relatively new. I'll say a word on that. PDAC, and it wouldn't be me if I didn't say one word at least about antifungals and storage media, which I'll do at the very end. Okay, so what of all these things are new about DMACC? Well, we started by injecting the graft into the eye. There are now many, many different ways of not only unfolding the graft, as has been alluded to earlier in Professor Sharma's talk, but also injecting the graft into the eye, or in this case, Donald Tan's technique of pulling the graft into the eye. So different ways of getting that graft through the wound. In the US, a big innovation that's really been helping me is the fact that we can get pre-stained, pre-stripped, pre-loaded DMACC tissue. This is Mark Terry's description of that, and you can see the scrolled up DMACC tissue in the modified Jones tube. The CorneaGen offers a similar thing in a goiter cannula here. And basically you can get tissue arrive in your OR ready to inject into the eye. And that's been a huge source of efficiency for me anyway. Femtosecond laser assisted DMACC, an interesting concept. This is using the femtosecond laser to cut the donor. This paper by Vishal Janji. What I think is even more fascinating is using the femtosecond laser to create the scoring on the host, not on the donor, but on the host. And I think it's particularly useful in cases such as here, if previously failed PK, where we don't want to be too aggressive about scoring and stripping so that we don't disturb the old wound. But this particular study, though small retrospective, showed that by using the femtosecond laser to create a very circular scoring with no irregular edges and tags, actually led to a lower rate of rebubbling needed compared to a manual stripping of Decimate's membrane. So maybe we'll see more about femtosecond laser assisted DMACC. We've all seen Garrett Mellis's concept of using less tissue for a DMACC. So in this case, hemi-DMACC as he first proposed. And you can see here the semicircular graft here. And then even for Fuchs using quarter DMACC, and thereby possibly allowing one graft to be serving 4 different recipients. What I think has been a huge, huge progression for us is the learning curve for DMACC. And we've been able to overcome that because of our teaching ability. The simulation that Chris Salas here devised using these artificial anterior chamber with a latex diaphragm to simulate the anterior and posterior segment pressure dynamics has been really revolutionary to help us teach others how to do DMACC in wet lab setting. And I think this has been very, very important. We use this when we do our Cornea Society wet labs. And teaching to get over the learning curve is essential. This is Sophie Deng and I went to China to teach DMACC. And now that we can't travel, what are we gonna do? Well, necessity drives innovation. And so this is myself teaching virtually how to do DMACC surgery. And this was a Cornea Society function that was done in collaboration with Eversight. This is the wet lab that we teach every year to our US cornea fellows. And we couldn't travel. And so what happened was that Eversight actually sent these artificial anterior chambers, much like Chris Salas described, and DMACC tissue to the fellows, who brought them to their operating room, hooked up their iPhone to the microscope. And I could actually feel like I was sitting next to 2 different fellows and instructing them on where to tap and what to do with the anterior chamber fluid. And I was able to get these 2 fellows to be able to learn how to do DMACC and unscroll that the tissue successfully. So this is very, very new, and I hope that we can expand our teaching efforts worldwide because of this technology. A word about endothelial cell culturing. This is technically replacing endothelial cells. And we've all seen Professor Kinishida's New England Journal paper that came out a couple of years ago, talking about how to inject these cells and having patients lay prone. But this year new is his publication of the 5-year follow-up, and 10 of his 11 first patients continue to do very, very well after this was done. You can see here an example of the cornea cleared. I'd be remiss if I didn't talk about Professor Agarwal's pre-Decimated endothelial keratoplasty. This is not a new concept. This was conceived many years ago using the big bubble technique to create a type 1 bubble. Allows us to use potentially younger tissue and easier handling inside the eye. And we've had some different ways of optimizing doing this technique, and this is relatively new as well. And then finally, again, it wouldn't be me if I didn't talk about antifungals. I think that there's still a lot of research to be done, and there's still some debate. I obviously vote on the side of considering adding antifungal, but I'm not 100% sure exactly which antifungal nor which concentration is best. However, what is new is that a major eye bank in the US does actually offer the addition of an antifungal into commercially available fluid for storage prior to endothelial keratoplasty. So in conclusion, I think that a lot of new things have come around for replacing the corneal endothelium, specifically for DMACC. There's a lot of innovations, and the biggest one I think is that we can teach it virtually. We've proven that we can. PDEC is becoming a little bit more popular. Corneal endothelial cell transplantation is coming, and the antifungal debate continues. More research is needed, but I'm excited for all of these things to see what's going to happen even in just the next year. So I want to thank the organizers once again for inviting me to be here today. It's a pleasure, and so far it's been a wonderful conference.